translating evidence into clinical practice. Now we have a lot of evidence at our fingertips, but how are we utilizing it in our everyday practice? We have 5 speakers here. Let's start off with a keynote address by Dr. Tara Prasad Das. I'm sure Dr. Das doesn't need an introduction here. He's my teacher. He's a renowned Retina specialist and into basic research now. Dr. Das will give a keynote address on eye care policy planning in people with diabetic retinopathy in India and South Asia. Over to you, sir.
Thank you, Thomas, and thank you, friends. And good to be in Thrissur in KSOS. My first meeting actually in KSOS, though I've gone to Cochin or Trivandrum, Kerala several times. When Thomas talked about it, I offered him 2 topics. One is this, which is a public health policy, because very important to have public health policy for whatever health care we do. And 2 is a very, very basic biological research, molecular biology research, which Andy preferred to this, and let us talk about this. Before we talk about the health policies for DR care, talk about these few terms are used very repeatedly and explain to you what they are on the health system. What is the socio-demographic index called SDI, what is the epidemiological transition level called ETL, and finally, what do you mean by daily disability adjusted life years. Health system has got 2 principal actors. One side the people who consumers, people who receive our patients, and 2 the providers, either the health providers like public or private or voluntary, non-for-profit, or the state, which let's say in India, health is a state policy. There are 2 important inputs. One is the finance. Finance is revenue generation and revenue and purchasing power of people. And the 2 is the knowledge of pharma industry participation and the technology that we are changing every time. This all together give to a service delivery for public, private, inpatient, outpatient, etc. But ultimately build a system which is not only for cure of a disease but also health protection. It is much more important than cure of disease, and build a trust in the system. When you say that I am become unhealthy, I will taken care of, the system trust is very important. This all lead to a oversight of the entire system called the regulation, information, policy, planning, strategic, then partnership between the government and the public and private partnership, etc. When we talk about the SDI, 3 important factors. One is what is the income per capita per person. That means what is the average education for the people above the age of 15, and what is the fertility rate below the age of 25. And then SDI goes, certainly 0 is the lowest, but then higher SDI, which is more than 0.6, means there is a higher education, a lower fertility, and higher income per capita. ETL is the other way around. ETL is the ratio between the all common maternal communicable neonatal diseases divided by all the NCDs plus the injuries. Here, higher ETL means more double. That means more injuries, more non-communicable disease than compared to people dying of infection. So these 2 are important. Finally, the daily is the measure of disease burden expressed as the number of years lost either because of disease or early death. As is shown here, there are small time death, but then they will die before. These 4 factors actually decide how healthy we are, how healthy the state is, and all entire communication based on this. ETL has got 4 different categories. One is before early 17th, 18th century, when the pre-Renaissance days, so there is a higher morbidity and higher mortality, higher birth rate, but because of higher mortality infection, the population is very, very slow. As you grow after Industrial Revolution, the population grew, then the fertility increased, so population will grow. This is called population boom that we had, India still has got most probably. As you grow further, then we know how to control our fertility. So mortality become less low because of our health system improved. The slowly population went down. But today, when we are in 21st century, because of even though there is a low fertility and more knowledge, because of better health system, population is low, but then we are dying because of non-communicable diseases. So where you are actually? We are in the somewhere in the middle. That India or entire South Asia, Afghanistan, Pakistan, Nepal, Afghanistan, Sri Lanka, Maldives, the South Asia countries, we are somewhere in the middle, where our infection has come down significantly. So do not die of polio, do not die of malaria, do not die of rubella, something like that. But then non-communicable disease increase because of many things. Lifestyle changes, our not controlled diabetes, hypertension, etc., etc. So we are here. This actually decide where do we go from here. Unfortunately, so-called developed countries are in higher there. So USA, UK, Japan, France, Australia, they are not no more actually controlled society. Where do we stand? In India, so we divided all the states and union territories. There's published paper in 2016. It will not been done after that in India, unfortunately. There are five states are actually higher ETL, and Kerala is one of them. Others are Goa, Himachal, Punjab, and Tamil Nadu. That means you have got a lower mortality, health index is better, SDI is better, income is better, but non-communicable diseases also are higher. If you look at the three other factors, the Human Development Index and the poverty index and the out-of-pocket spending called OOPS spending, then India is somewhere in the middle of the South Asia, SDI is 0.6, multi-dimensional poverty is 16.4% people are actually poor in the country, then 50% people pay out of the pocket. In Kerala, however, there is a better SDI at 13% better SDI than India average, 95% lower poverty than India average, but the out-of-pocket expense is much higher, 34% higher than what normally people in India will pay from their pocket for health care. This is the India average of diabetes and diabetic retinopathy, and Kerala is highlighted here. We have got 25.5% of DM, 22% of any diabetic retinopathy, and 5% of DR, which is much higher than the India average shown here. But diabetes is not a standalone disease. If somebody thinks that diabetes, nothing happens, it is not really true. And we published a large paper of 11,000 people, entire country from North Punjab to Tamil Nadu, that hypertension is very, very common. 58% people have comorbidity, and hypertension is the most common of them. As similar to diabetes, retinopathy is also not a standalone disease. Incidentally, the amount of people of diabetic retinopathy who have cataract is very high, which is 77.7%, which is non-operated or operated together. But why I'm talking about cataract in a situation like a diabetic retinopathy? Because the cataract actually signifies the robustness of healthcare or eye care for this matter. In India today, CSR is 59 or 6,000, which is very, very high, but desired actually 9,000. That means you are still behind even though they are doing so-called good. Let's see what actually happens. This is a beautiful graph which shows that as you develop further, your health system actually depends on how well you do a cataract surgery or how effective you do cataract. Example, look at the countries, USA, France, Netherlands, Japan, Iran, all are doing much better than compared to Brazil, Chile, Cuba, China, South Africa, etc. Because please do not say that I don't care for the cataract. That is the basic of the eye health system actually. So how to treat that means retinopathy? You do a screening, either biochemistry or a fundus photography. You identify between NEDR to STDR. STDR requires immediate treatment. They then do either laser, surgery, injection, depending on the status of the retinopathy, and do a follow-up care. But the published paper, I think 6 months ago in Lancet Global Health, we published that Smart India study found that 28% of the times you cannot take a fundus photography because of lens opacity, which means that these guys require a surgery for cataract first or care for cataract first before you think about diabetic retinopathy. So that's also the study identified 3 important criteria. People who are older than 50 years of age, diabetic duration more than 6 years, and people with a systemic blood pressure of 440 millimeters of mercury have a higher risk. If you use these 3 criteria alone, then in a screening strategy, 93.5% people were able to screen well. That means you are not losing too much. In a resource-restrained situation, not Kerala though, situation where you do not have all the resources, then at least you people screen people above the 40, 6-year diabetic duration, and blood pressure of 140 over 90, then most probably 93% of times you can identify STDR. Look at this, the India scenario. Now, Government of India said last year we operated roughly 8 million cataract, and then Smart India study had identified that 4 million people of India have required treatment for retinopathy. If you convert that into money, then you require 96 million US dollar for cataract surgery and 154 million for retinopathy care. So what you will do first? You might hate me, but then health policy wise, you should don't ignore the cataract while not ignoring the retinopathy. And then cost of is that for individual is three times, for the country wide 3 times more expensive than doing a cataract surgery. So where we are today, we projected that IDF says that 74 million people have diabetes in India. But recent paper in July published paper of one group from Madras says that actually 101 million people of India have diabetes, but along with the undiagnosed or pre-diabetics, there are 237 million, and importantly that 315 million have got hypertension, and obesity is 254. In general, all India studies shown that urban is more than rural, diabetes or hypertension or anything else. But unfortunately, this is blurred in Kerala. Now, in Thrissur, the study says that retinopathy is higher, so also maculopathy and STDR. In Kerala, says that diabetes is much more than in India, both diagnosed and undiagnosed, so also hypertension, obesity, and abdominal obesity. Look at those beautiful figures published in Lancet Global Health, that is urban rural. Look at those figures that both are red, that means blurred between diabetes in urban and rural, so also pre-diabetic, so also hypertension. That means in Kerala nothing called rural, it's everything is urban. So also obesity. So considering that the cataract surgical rate is very high in Kerala, almost 5% more than India average, we do not have the data for CSR and effective cataract surgical coverage. Considering that even a state like Tamil Nadu, higher cataract surgical rate requires, still there is a huge gap in effective cataract surgical quality of the cataract surgery. We have to improve also the cataract surgery along with everything else. This aligned with the WHO recommendation for the integrated people-centered eye care, from advocacy in the community to tertiary care and higher level. My suggestion is that Kerala requires to improve the cataract surgical rate also without ignoring the diabetic retinopathy. Thank you very much.
Thank you, sir. Just one question from my side. When you go ahead with these policy plannings that Kerala requires a better cataract surgery site, more screening and all, don't we have to look at the health-seeking behavior of the population also?
I didn't understand the second line. What is the second line?
Don't we have to look at the health-seeking behavior of the population also, rather than screening and treatment?
Yes, advocacy. The advocacy to reduce the hypertension, reduce obesity, and change your food habit. This has to happen in the lower level in a so-called health wellness clinic or primary care center, then go upwards. As the SOAS paper talks about that Kerala diabetic retinopathy pathway, you don't require to do you require universal screening, don't have to do those targeted screening. We are doing very well, but then incidentally still we are behind, so Kerala can be a good model, can be a better model for the country to how to do the policy planning for DR. The problem is that we retina guys always say screen and treat diabetes, but can't ignore cataract eyes, because people are older people, they will have cataract, it's not a disease, will have a cataract also. So that is why my suggestion is that when you improve the system, improve the entire system, just not the retinopathy or screening or fundus camera, etc., also how to improve the cataract. That will improve the availability of human manpower, a lot of personnel, cataract surgery, infrastructure development, everything will go together. Then you can do much better than what we are doing today.
Thank you, sir. Thank you very much. And let me invite Dr. Praveen Murali to give his top 10 messages in the management of diabetic macular edema. Praveen Murali is consultant vitreoretinal surgeon at the Eye Foundation Hospital, Cochin.
Thank you, sir, and I thank KSOS to give me this opportunity. So from the previous lecture, we already know that it's an epidemic. And as the epidemic rises, the incidence of diabetic macular edema will increase. And the most common cause of moderate visual impairment among people with diabetes is DME. So today's talk is on top 10 messages in the management of DME. I'll go in stepwise, where we first start with the history. So the duration and control of DM is very important. So each time a patient comes to you, this is should be insisted, ask for HbA1c. If we keep repeating this every time they come, at least we take the first step towards the control of diabetic mellitus. Along with that, the systemic comorbidities also can be asked, like hypertension, hyperlipidemia, anemia, and renal disease. Second is the visual acuity. The best corrected visual acuity should be taken. This not only helps to help in assessing the progression, also to see for the treatment response also. When we come to examination, have a good look into the eye, see the pupils nicely, see for the margins of the pupil, to see for NVI, NVAs, check for IOP, see for the how the pupils are responding to dilatation. And then go ahead with dilatation and see the fundus with both 90 diopter or 78 diopter lens, or a 20 diopter lens. FFA as such, the role has become very less in case of DME. However, you can classify, once you do an FFA, into focal and diffuse. Most important is to see for macular ischemia. So what you can see in this is not just enlargement. More than that, just see for notching. Any notch can suggest in form of macular ischemia, or you see for any aneurysms at the edge of the FAZ. So that also can signify macular ischemia. With the advent of OCT and anti-VEGF, OCT is now widely used and is the most common imaging tool used by all of us, not only for diagnosis, however, even for prognosis and follow-up of diabetic macular edema. It has multiple poor prognostic factor, which when you see can tell the patient about the prognosis of the patient, and we can say that mainly whatever management we are going to do is for just to sustain the same vision. So features like drill or loss of outer integrity of the outer layers and all can be seen and explained to the patient. You can also see the tractional component, and if there, then we can suggest treatment accordingly. Coming to the management, at present we are divided basically into non-center involving or center involving diabetic macular edema. So when we say non-center involving, see the OCT image, the central grid is the central and the rest of the area are called non-central. The management varies. So when we come to the management, the non-center involving, you can consider as to observe. It's not a mandatory to teach such patient. Why so? Because the long-term study, whatever multiple studies we have, the progression from non-central to central is only around 15% over the year of over 1 year's time. So during this time, you can advise them to have a very good control, do an HbA1c, do for lipid profile, send them to a physician to have a good control of the systemic factor. And if needed, you can, this is one of the indication where you can do a focal laser. You can see those aneurysm, you can hit the aneurysm, you can even do an angiograph, see for those leaking aneurysm, and you can treat them simultaneously. For center involving, now with multiple trials, we know that anti-VEGF is like a standard for treatment for center involving diabetic macular edema. However, when you want to switch to steroid, or when you want to give steroid, they can be given in patients who have reached a plateau where there is persistent intraretinal fluid with multiple treatments, or if response to anti-VEGF is there, but sometimes the patient finds it difficult to have a follow-up. Patient requiring cataract surgery, you can give. Eyes where it has undergone a vitrectomy, long-term depot steroids are helpful. And in patient who had some vascular event like myocardial infarction, stroke, any thromboembolic phenomenon, they can go ahead with intravitreal steroids. When we consider surgery for patient with DME, so we can go ahead when there is a VMT, ERM, STOT, posterior head. These are the main indication. The role in recalcitrant DME is doubtful. A large series which had come recently shows not much advantage. So other than the traction which is released during the surgery, it also helps in other hypotheses which are given is it can help in better oxygenation to the inner retina, can improve the capillary blood flow, reduce hypoxic induced VEGF drive. So, last but not least, the most important thing is control of systemic factor. So keep insisting for all these patients about the glycemic control. So this is very important. Ask for HbA1c every time they come. Many physicians may not insist, many of them go to a general practitioner. So if we can insist again and again, because they will follow up with you every 3 to 6 monthly. So if we can insist over the period of time, they may realize the importance and have a good control. Along with that, other factors like blood pressure, renal status, lipids, they are all important. Have an evaluation and you can send to the physician for adequate control. Last, just few topics where you have a mix what to do. Like when you have a PDR with DME, you can either go with a anti-VEGF treatment plus or minus PRP as and when required, but don't just leave the patient with just injections. Cardiovascular event, I have already told that should not be initiated if it is within the 3 months period, but anything after that you can give, but always consult a physician or take the physician into the loop before going ahead with the injections. Sleep apnea is one thing which is not commonly looked into, so we can all try to ask for some history, and if it is there, treatment for the obstructive sleep apnea like CPAP has shown to stop or reverse DR and DME progression. And during pregnancy, the use of intravitreal anti-VEGF is not recommended because of the potential effects on the developing embryos on fetus. However, if there is a progression of progressive loss of vision, then you can consider intravitreal steroids, but should explain clearly about the possibility of cataract and glaucoma to the patient. Thank you.
Praveen, would you routinely advise FFA in your DME cases and your PDR cases?
So nowadays, with the advent of OCT, OCTA, the role of FFA have reduced significantly.
Even in your PDR?
One case where I feel it is indicated is asteroid halosis, where you can catch on NVs. That was the pictures which I had shown actually. It was with asteroid halosis, and you can easily pick up NVs clearly.
I still think of FFA in a after treatment, not before treatment for PDR. And if I have a larger wide-angle fundus camera, then I can take the peripheral areas where you can. OCT NGO right now is not really wide-angle most of the time, and it cannot get the subtle ones, very fine ones cannot sell. So those areas. Pre-treatment, PRP treatment, fluorescent angiography is most probably not required today.
Thank you, Praveen. Please join. And now I would invite Dr. Jyoti Prakash Vyas for his talk on 10 pearls in the diagnosis and management of central serous chorioretinopathy. Jyoti is a consultant vitreoretinal surgeon at Giridhar Eye Institute, Cochin. Over to you, Jyoti.
Thank you, sir. I thank KSOS and the scientific committee for giving me this opportunity. So I'll be taking the topic on pearls in the management of CSCR. I've deliberately omitted the number 10 because I don't know whether I'll be able to cook up 10 pearls actually or not. So coming to the rough introduction onto the CSR, it's a localized serous detachment of the posterior pole, which are focal detachments of the RPE, with usually seen in two clinical forms like acute and chronic. Acute, by definition, is of less than 3 to 4 months of duration, and anything more than that is variably called chronic CSR. The chronic CSR has a specific entity when it is seen in patients above the age of 50 years, and it often resembles CNVM or ARMD, and it is often complicated by a similar picture. It has a higher prevalence in males, about 6 times more in women, 6 times more than women, and the age of presentation is usually 39 to 51. With the advent of Octa in clinical practice since 2014, it has helped to visualize specific patterns of CSCR and the management therefore. Octa changes in CSCR which are usually seen are hyperperfusion and flow voids, and also new networks which are seen in some ambiguous cases. The main goal of treatment in a CSR case is actually going to be complete and durable resolution of SRF and improvement of the visual acuity. Looking at the science, what we have understood over a period of time, the first thing which came out was in 2016 when Wong et al. Had put forward a few of the parameters which we usually look in the history as well as the management protocols, which are based on the available level of evidence. They are defined the evidence as good, fair and poor according to the standard definitions. So in the risk factor modification, the quality of evidence was extremely good for glucocorticoid discontinuation. So if you discontinue glucocorticoids, an improvement in CSR is definitely seen, whereas pregnancy and delivery and phosphodiesterase inhibitor withdrawal had only a moderate amount of, or you can say a fair amount of evidence that they really worked in this treatment. As opposed to diabetic retinopathy, obstructive sleep apnea does not actually have a significant effect in management of CSCR. The treatment modalities which have been there for quite many years, only PDT and focal laser have a good quality of evidence. Anti-VEGF and sub-threshold micropulse only stand at a fair chance of quality of evidence, whereas the much fabled mineralocorticoid receptor antagonists do not enjoy that level of evidence. The treatment options were initially based on the finding of choroidal abnormalities on ICGA and also on FFA, but ICGA definitely showed a significantly high amount of changes as opposed to FFA. So treating the choroid with PDT based on the choroidal findings on an ICGA happened to be the best treatment available. In acute CSR, the treatment paradigms which are used right now is, which has been followed for many years together, is observation for an initial period of 3 to 4 months and waiting for spontaneous resolution. After 3 months, if the OCT does not show any resolution of SRF or if there is a residual amount of fluid, we subject the patient to an fluorescein angiography and an ICG. And in case of an active leak, this can be treated. If it is a subfoveal leak, a PDT can be done even in an acute CSR, and if it is an extrafoveal one, probably a focal laser to the leak can be done. This is just to show post-focal laser how the CSR tends to resolve and a normal foveal contour is achieved. About 15 to 50% of patients of acute CSCR who are not treated actually tend to have more than one recurrence over a period of 1 year. And they say at some point of time in a conjecture, they come to the point that in acute CSCR, PDT can be used when the fluid is persistent for more than 3 months. According to Ozkaya and Mohabbati, they also showed that post-PDT, the number of recurrences also reduced from a 24% in the untreated state to 4% when treated with PDT. In chronic CSCR, Januzzi had initially postulated this way back in 2000 that based on ICG abnormalities, treating with PDT led to a significant improvement in the clinical condition of the patients. And since the SRF is a waxing and waning pattern seen in this disease, they actually followed that treatment only. Until that time, about 2018, there was no randomized controlled trial which actually looked into the various other treatment modalities for this disease. Following the PLACE trial, they found out that PDT is better than subthreshold micropulse laser. The improvement chances improve from 67% in PDT, whereas it's only about a meager less than 30% in micropulse laser. PDT in different concentrations was used. They say 1/3 dose PDT is better than half dose PDT, and half fluence PDT was the least effective. Van Dyke et al. Also showed the superiority of PDT in this, as I've previously mentioned, and they also showed that the retinal sensitivity also improved. So treatment in CSR patterns, if you just look at this flow chart, in a patient who lands up with an acute CSER in your clinical practice, the best treatment would be an observation for the initial period of 3 to 4 months, following which, when the patient is re-examined on an OCT, if the fluid is present, we do an FFA, ICG, and also an OCTA to look for an evidence of any leak. If the leak is present, that leak is treated with PDT. If it is a foveal leak, and if it is a peripheral leak, you can do a focal laser. If in case following this treatment again there is a persistence of fluid, the same protocol is followed, and if on an OCTA there is the presence of a network, probably a role of anti-VEGFs is there. Mineralocorticoid receptor antagonists, although have been much favored in the recent past, but they say they only provide complete resolution in only about 2/3 of patients. Eplerenone and spironolactone are said to be almost equally effective, although eplerenone is more sensitive, more specific for the receptor, whereas spironolactone has a 40 times more potency towards the receptor. But eplerenone is preferred due to a favorable safety profile, although both of them have a similar problem with elevation of potassium levels. And the recurrences post-spironolactone are more likely than after half-dose PDT. And the only positive thing which was seen with the use of spironolactone was the reduction in the thickness of the choroid when the patient was on treatment. The recently released VC trial in late December 2020 and early 21, it categorically stated that mineralocorticoid receptors are no better than a placebo, and clinicians should avoid using these. And in chronic CSIR, the treatment is no different. Again, you have to start off directly with an FFA, ICG, and an OCTA, and based on that, you have to treat accordingly. Laser photocoagulation, when the CSCR is complicated by subretinal macular neovascularization, the incidence was seen to be around 2 to 18%. And this most important thing is that it's a sub-RPE leak, and due to a PCN, it can mimic even an uncomplicated CSCR. So OCTA is mandatory in this subset of patients. So the take-home message for treatment of patients with CSCR is an acute CSCR, initial observation, followed by re-evaluation after a period of 3 to 4 months. In chronic CSCR, subjecting the patient to angiography, OCT, and OCTA. And in chronic CSCR with PCN, keeping in mind the evidence of half-fluence PDT along with a combination therapy with anti-VEGF or a monotherapy can be considered. Thank you.
Thank you, Jyoti. Jyoti, in a CSR which has developed into a CNVM, what would be your line of approach? What would be the preferred line of approach?
Preferred line of approach, according to the Everest trial, would be a combination therapy of half-fluence PDT along with an anti-VEGF. But usually in the given scenario right now, PDT is not very easily available in India. So probably starting off with a monotherapy, and probably adding in some level of sub-threshold micropulse laser can be given to the patient.
Can I ask one doubt?
Yes, sir.
Yeah, from the audience.
Yes, sir.
Same thing just now what Dr. Thomas also asked.
Yes,
Because you have mentioned that treatment modalities. But for persistent CSR, as of now, since PDT dye is not available, so what can we actually do for the patient?
Sir, although VC trial has categorically stated that we do not need to and we should not be using eplerenone or spironolactone, but eplerenone, some patients do exceptionally well, but it's a very variable response. So it is not a response which is going to be reproducible in every patient. So that is one trial which can be given. Micropulse laser, subthreshold micropulse laser has the benefit of low cost and the possibility of a repeatability at 3 months if it does not respond favorably. So that can be repeated without any additional permanent damage to the RP in such a case.
We have a couple of patients who we have done all this, even micropulse
Yes, sir.
repeated, but still it's persisting.
Yes, sir. You are very
So,
correct on that. Unfortunately, it's a very tiring disease. It doesn't go very easy. Had the PDT been there, it would have dried off very easy.
Yeah.
But PDT, unfortunately, at the present moment, is not easily available to us.
So as of now,
Nothing much. Probably micropulse subthreshold laser is the only option which is the least damaging, potentially repeatable, and most easy on the pocket to the patient at least.
Thank you.
But I will be extremely controversial to what I told. The recent paper published in IJO says that in those persistent, not respond to anything, intravitreal dexamethasone might work. It's not my take, I'm only quoting a paper.
It's thank you, sir.
Thank you, Jyoti. Please join the site. And now I invite Dr. Divya Balakrishnan. Divya is consultant vitreoretinal surgeon at Little Flower Hospital, Angamali. Divya will talk on panretinal photocoagulation versus anti-VEGF management of proliferative diabetic retinopathy.
At the outset, I would like to thank Dr. Thomas Cherian for giving me this opportunity to present before my two gurus, Dr. Thomas Cherian himself and Dr. Das. So how do I treat my patient of PDR, whether it is PRP or anti-VEGF? So before going to how do I treat, let's look at the evidence, what it says. So as we all know, diabetic retinopathy is a microvascular complication which lead to ischemia and result in retinal hypoxia. So the clinical features of PDR results because of this, which is NVE and NVD with vitreous hemorrhage and pre-retinal hemorrhage. As you all know, it is a progressive disease with progressive retinal ischemia. So the treatment aimed to target these retinal ischemia and the sequelae because of the hypoxia, that is anti-VEGF. So the aim of treatment in PDR is to reduce the VEGF levels and increase the oxygen supply. So these two treatment modalities, that is anti-VEGF and PRP, both works in this. So how do we decide? Any diabetic retinopathy patient, the first and foremost is the systemic control. And for PDR, PRP has been the standard of care after the landmark trial diabetic retinopathy study, which showed that with PRP, more than 50% of the patient, the risk of severe vision loss was reduced. But there are complications of PRP, which is a permanent peripheral vision loss, decreased night vision, or risk of diabetic macular edema. And despite PRP, patients can develop severe vision loss and can develop vitreous hemorrhage. So these are, this is a serial photograph of a patient who was treated with the PRP, and you can see despite the treatment, the patient developed vitreous hemorrhage over time. So is anti-VEGF a better option? So Protocol YES was the first trial which looked at the role of anti-VEGF in the treatment of proliferative diabetic retinopathy. So what does it show? So in this study, the patients were treated with monthly injections of ranibizumab versus PRP. So this was the first trial to show that anti-VEGF was non-inferior to PRP in treating PDR. So thus we have two options to treat PDR, anti-VEGF and PRP. And the main concern of anti-VEGF is that the risk of traction progression, and the advantage being that whether the visual field will be preserved. So the 5-year outcome of this study, which showed that only 66% of the patients could complete the trial, the follow-up period, and it showed that the visual acuity at the follow-up of 5 years was equal between these two groups, that is anti-VEGF and PRP. And over period, 19.2 injections were required in the group of ranibizumab, while only 5.4 injections were required in the group for PRP. But none of the group had any severe vision complications. So the main advantage of anti-VEGF being a preservation of the visual field, a subgroup analysis of this study showed that at the end of 5 years, the margin of difference between the visual field preservation at the 2 years were not there at the end of 5 years. So the difference had narrowed. So even in the patients with anti-VEGF, there was a reduction in the visual field loss. And Clarity was the next trial which looked at the comparison between aflibercept and PRP. So this was the first trial which looked at and showed that aflibercept is superior to PRP in improving best corrected visual acuity in cases of PDR, and it also showed that it is non-inferior to PRP in regression of neovascularization. The PRIDE study was another one which looked at compared between ranibizumab and PRP with PRP alone group. So this, at the end of 1 year, all the ranibizumab and the combined group had better visual outcome, but on observation, without any active intervention, when they followed up the patients at the end of 2 years, the advantage was not there, and adding on to that, there was an increase in the area of neovascularization in the group which had received anti-VEGF and the combination group. So if we discontinue the treatment of PDR with anti-VEGF, there is a chance that the disease can progress, and without intervention, the patient might lose vision. So when we consider treating the patient with the combination, which one would you do first? So this is a trial which looked at it. In that, the first group received anti-VEGF first, followed by PRP. The second group received PRP followed by anti-VEGF. And this showed that the group which received anti-VEGF first required less extent of energy to deliver to get the desired burn, and also the need for retreatment was less in this group. So this study showed that anti-VEGF followed by PRP might be a better option. And another option which we think, or the advantage of anti-VEGF being whether it is disease modifying. So this was a study which was done only on 7 eyes, where they looked at after 3 monthly injections of aflibercept, they looked at the octa non-perfusion areas in octa compared with the microperimeter. So there it showed that in 52% of those areas which they looked at, there was an improvement in perfusion, and that compared with the improvement in the microperimeter. So there is a hope that maybe anti-VEGF might be disease modifying, even though other studies did not prove this. And coming to the next aspect, when we have a patient of PDR with vitreous hemorrhage, whether you take up for early surgery or whether we treat with anti-VEGF. Protocol AB by DRCR-NET was the first trial which looked at into this aspect, where they treated patients with vitreous hemorrhage with monthly injection of aflibercept and take up for early vitrectomy in the other group. So in the study, actually, they looked at the results at the end of 1 year, 4 weeks, 1 year and 2 year. So they showed that at the end of 1 year and 2 year, there was not much of a significant difference between these two groups. But when they looked at the best corrected visual acuity at the end of 4 weeks, the group which had vitrectomy had a better visual outcome. So that is actually explainable by the kind of surgery which we do, intervention early by doing a vitrectomy. But another advantage of this study was that the recurrent vitreous hemorrhage was seen in 49% of the patient who received aflibercept, while only 15% in the vitrectomy group. Now, in the subgroup, in this study, they did a subgroup analysis. If the patient had presented with a worse visual acuity, that is less than 20/800, does a vitrectomy has an early role? So this showed that those patients with a poor visual acuity, if you take up them for early vitrectomy, they had a better visual outcome. Now, as I mentioned earlier, whether there is a risk of progression of tractional retinal detachment after you give anti-VEGF, which is a scare for many of us. But they analyzed the pooled data of various studies in the DRCR-NET. They showed that the cumulative probability of the progression was comparable with the control group. So the risk, as we anticipate, is not there as we think. The major concern is the patients who are lost to follow-up. So in this, even in the protocol, as we saw that almost 50% of the patient actually was lost to follow-up. And when we did the analysis of those patients who were lost to follow-up, those patients who had received anti-VEGF actually had a higher risk of developing tractional retinal detachment and neovascularization compared to eyes which had received PRP. So the main concern is that if the patient is lost to follow-up, then the risk of patient presenting with complications is on the higher side. On the other hand, we already have evidence from the ETDRS trial that the patients who are treated with the PRP, 42% of them retain 20/20 vision over a period of 16.5 years. And even if the patient develops a vitreous hemorrhage, when we do vitrectomy, the visual acuities are comparable. So in real world practice, loss to follow-up is the most scary thing when you treat a patient with anti-VEGF alone. So as of now, this is an article which by Dr. Rajiv Raman. So they say that selecting a patient with PDR for anti-VEGF therapy as of now is active PDR in which despite good PRP, there is a persistence of new vessels, or when there is a difficulty in performing PRP, preoperatively before a diabetic vitrectomy to reduce the risk of intraoperate bleeding, or an anterior segment neovascularization, or DME with PDR, or an adjuvant to PRP. So these are few cases wherein the patient presented with vitreous hemorrhage. We could not do laser, so the patients were given anti-VEGF and followed by the resolution of vitreous hemorrhage, PRP was added. So I don't treat PDR patients by monotherapy, use it as an adjunct. Thank you.
Thank you, Divya. A PDR with a pre-retinal hemorrhage at the macula, would you go for a PRP or an anti-VEGF?
At the premacular area, if there is no vitreous hemorrhage, I still go for PRP first. Then only I go for a vitrectomy.
Any further questions to Divya? Due to paucity of time, Divya, please join us here. Let me invite Lekha for the last talk in this session. Lekha is consultant in medical retina at Giridhara Institute, Kochi. Dr. Lekha will talk to us on anti-VEGF in wet AMD, simplifying treatment paradigms based on evidence.
Good afternoon. I thank Dr. Giridhar sir, who unfortunately cannot join us today, Dr. Thomas Cherian, and Scientific Committee of KSOS for giving me this opportunity. But before I start, I want to pay respects to my beloved chief, Dr. S.S. Badrinath. So age-related macular degeneration, or AMD, is an important cause of blindness in elderly population, and it affects about 3.1% of the population in India. The hallmark of neovascular AMD is choroidal neovascular membrane. The visual loss due to CNVM not only affects the lifestyle and the independence of a patient, but the treatment of AMD itself causes significant economic impact on the nation. And the discovery of vascular endothelial growth factor, which we call it as VEGF, was an important milestone in our understanding about AMD, and the subsequent development of the anti-VEGF drug have really changed the way that we manage the disease. Followed this was a series of randomized control trials which proved the efficacy of these anti-VEGF drugs, but unfortunately the superior outcome which was demonstrated in the RCTs could not be translated into real-world evidence. So we will look into this in more detail. These are the various anti-VEGF drugs that we have at our disposal, starting from bevacizumab, ranibizumab, aflibercept, and the latest one being brolucizumab. And there are a lot, these are some of the major trials that has been conducted on these different drugs, utilizing different regimens on different populations, and all these mostly demonstrated good structural and functional outcome. It definitely helped to reduce the rate of visual impairment due to AMD, but these results were not seen in real life over a long time. So let's go into a little more detail. The first regimen that was tried was a monthly regimen, which was used in the major trials Anchor and Marina. And this is which proved the efficacy of ranibizumab as a treatment for neovascular AMD. And this set the bar for the newer therapeutic approaches, because the use of this drug not only helped to stabilize the visual acuity, but actually caused a gain in a significant number of patients. And for the first time, we were experiencing a gain compared to what was happening in the laser and the PDT era. But the main problem here was a significant burden due to the necessity for monthly injections. So this changed the trend towards PRN or Pro-Renata, where the patient continued to visit every month, but the injection is decided only based on the activity of the lesion. But this unfortunately could not maintain the visual gains over long term. And moreover, even though the injection was not given, the patient still required monthly visits. So the next attempt was to make it into bi-monthly dosing, and fortunately at this time aflibercept with a higher efficacy and a longer duration was available, and it was found that bi-monthly is almost as effective as monthly racimab, and we can see it could really reduce the number of injections that was needed. But still, this also was a significant treatment burden. It was only just once in month to once in 2 months. So we wanted little more individualized treatment regimens, and that led to the treat and extend strategy, where after the 3 initial monthly loading doses, you slowly start extending the interval of the visits by 2 weeks, but at every visit, irrespective of the situation, an injection is given. And at any time, if you see that, and if the disease remains stable, you can keep on extending the interval to a maximum of 12 to 16 weeks. But any time, if you see that the disease is active, you reduce the interval. So here it is more of a customized treatment. You try to give the optimum benefit of the anti-VEGF, but at the same time try to reduce the treatment burden. And it is found that this is now the regimen that is preferred mostly by the clinicians in US. So this is just to explain the same thing. Any activity, you give the loading dose, then keep them following up, and during follow-up, any evidence of reactivation, either in the form of a new intraretinal fluid or subretinal fluid, you have to reduce the interval. And when do you stop? When you see that already fibrosis has occurred, there is no more exudation, and if the patient is stable at 2 to 3 visits at subsequent intervals, you can either totally stop or then switch on to a PRN basis. And you should also be vigilant about the fellow eye in these patients. And we have a lot of literature evidence to support now that the T&D regimen works as good as a monthly regimen or the PRN, as good as a PRN regimen or the monthly regimen. And we can see that over the 12 months with 5.4 injections and 8.3 visits, we had a gain of 5 letters comparing to the 12 injections and the 12 visits that was required in the Marina Anchor trials. So what's happening in the real world is fewer injections, fewer visits, but little fewer visual gain. But still, these patients are protected from severe visual loss. So now we have little more options available, and the next new drug that has come is brolucizumab, which is the main advantages because of smaller molecular size. We have more drug per dose, so there is more affinity, more penetration, and also significant longer duration of action. And the Hawk and Harrier studies have proved that brolucizumab given once in 12 to 16 weeks can be as good as a monthly racemab. And moreover, these newer drugs caused much more drying of the retina, and they could maintain it for a longer period. It was especially useful in the treatment-resistant cases. But a little catch here is the risk of inflammation that was associated with the use of this drug, but that has been again controlled. And now we have a lot of data. This is like one of the largest meta-analysis comparing all the 4 drugs that was available, and that has shown that it is a proactive treatment regimen, that is a treat and extend, that is gives better outcome than the reactive, where you wait for a reaction to happen and then decide about the injection. And another factor which is important is the frequency of injections in the long term. So maybe we can follow a treat and extend regimen, but once come to the choice of the drug, all the drugs are more or less effective. But to start with, we can maybe start with ranibizumab or even bevacizumab or aflibercept. Aflibercept is especially useful when after the loading dose, if the fluid is still persisting, and in those recalcitrant cases, the other option we have now is a brolucizumab. So when do you change the drug? Is when you see that the fluid is persisting even after the first 4 aggressive treatment, or when you want to increase the interval, you can go for these newer drugs. But we should always remember that we need not dry up the retina totally as seen in the fluid study. We should also be aware of the conditions which can cause inadequate response. And what is now generally followed is after 3 to 6 injection, if your particular drug is not working, you can change it. And we have evidence here also where conversion switching to aflibercept or even to brolucizumab has given results. But actually, if you see, it is the anatomical improvement that is more important than the functional improvement. And the latest arrival, which is going to hit our market soon, is a faricimab, which is a bispecific immunoglobulin monoclonal antibody, which is effective not only against VEGF but also against angiopoietin 2. So it is supposed to give better vascular stability. And this also has been proved in the RCTs by name Tenaya and Lucerne. And this is found to has the potential to extend the interval with sustained efficacy. Here the interval has been stretched to up to 16 weeks, that is as good as 4 months. Another newer drug that we are going to have very soon is aflibercept high dose, that is 8 mg, which is also found to be superior to what we are available now. While these new drugs are emerging, we should also try to see what is the reason for this gap between the RCT and the real world evidence. And these are some of the important reasons that was found in this study. Not only it's a financial burden, but also the burden of visits, those who are dissatisfied with the treatment, and even the distance factors. So what's happening is once a patient has perceived lack of efficacy with the treatment, that will lead on to poor compliance, which in turn lead on to further decrease in visual acuity. And it is this visual cycle that we have to break. So we also need to have a change in our mindset that contributes to the under-treatment. And forever we keep talking about the economic burden to the injections, but let us look into the other side of the coin. What is the economic value of this therapy? So this is the question, what economic value do this treatment generate for the patients and also to the society? And it was found that the increased equity with anti-VEGF definitely provides economic value, and the more frequent the injections, the more is the value to the patient and also to the society. And we have another option, that is the role of biosimilars, which are not exactly the generic drug, but as good as a generic in its efficacy. And systematic meta-analysis has shown that these biosimilars can be a useful alternative, especially when affordability is the issue. So the future, we should have drugs with longer activity like brolucizumab, with better protein binding affinity such as aflibercept, or drugs with longer half-life, or we need to resort to alternate delivery methods such as the port system. So to conclude, anti-VEGF therapy is not a curative therapy, but it has become the mainstay and as a pillar in AMD management. It can slow down the disease progression and can partially reverse the visual impairment. As of now, TND appears a most promising regimen. Biosimilars can be a useful alternative, and newer drugs with longer duration can help to extend the interval, and they are very useful in recalcitrant cases. Ongoing trials and the newer therapies are exciting options as the treatment of this impactful disease continues to evolve. Thank you.
Dr. Lekha, nice presentation. So in your clinic, actually, what percentage of patients do you treat with treat and extend?
Actually, to be honest, it's not a significant percentage. I think most of us are still, after the initial loading dose, what we find is most of the time we end up doing the PRN regimen, but of late I've tried to switch more patients into TND, especially the one-eyed patients. There I'm able to convince them more that every visit they need an injection. But other routine cases, for me, personally, I'm in the evolving phase. I'm sort of in a transition from PRN to TND.
Thank you.
Thank you, Lekha.
Thank you, sir.
Dr. Das, please accept a memento from us. Please join us for